right. There'll probably be a few more joining us here shortly. But in the meantime, I'd like to welcome everyone to the Financial Sustainability for Complex Care. And this is our virtual site visit. My name is Melissa Benson. I'm with Behavioral Health Network of Greater St. Louis. A couple quick housekeeping things is please make sure your audio is muted unless you're speaking. We will be using the chat feature today to ask questions, make comments, offer information. You'll notice a lot of you, your videos are turned off at the moment. However, there will be an opportunity and time for you to unmute and be able to turn on your video and participate and engage in some conversation and discussion around financial sustainability. Please know that this session will be recorded. If you experience any technical difficulties, please reach out to me via chat, or you can reach me at mbenson@bhnstl.org. Please know that the materials from today's presentation will also be distributed in a follow-up email. At this time, I would like to pass this on to Wendy Orson.
Great, welcome everyone. For some of you, it's the second time I'm seeing you, so good to see you again. Really want to thank you for joining our financial sustainability discussion. I'm Wendy Orson, I'm the CEO of Behavioral Health Network. Our meeting today is going to be interactive. I want to give you a little bit of background information as to why you're here. Recently, the Behavioral Health Network and community partners were implementing a complex care model. We were recently funded by the Missouri Foundation for Health to work on addressing the needs of complex patients, or those who are super utilizers of care, who have multiple behavioral, physical health, social needs, all of which lead to extreme healthcare utilization. And the goal was to address this population through a behavioral health systems planning grant. The purpose today is to talk to you about complex care needs and to foster a shared vision to improve the care and outcomes amongst those with complex health needs. Another component to this work is figuring out how to reduce care utilization frequency and cost, and how to use our resources more efficiently together. You may be asking, as a fiscal leader, why am I sitting at this meeting? And that's a great question. Through this work, we've engaged technical assistance from Camden Coalition's National Technical Assistance Team, and I'm going to introduce you to those folks here in just a few minutes. Pre-COVID, just like all of you, we're responding to how COVID-19 has really required us to kind of pivot and change the way we do things. So pre-COVID, we had engaged this team who were going to be doing a site visit to come to the city and county and to engage you all in several different meetings, really addressing 4 different core key areas, one of which is the financial component. That's why we're here today. We'll learn a little bit more about what those other components are towards the end of the session. But the goal is really to educate you as kind of a first line bit of education for those of you who don't really understand complex care and the systems behind it. And secondly, to be very interactive and engaging today to solicit information from you. The information that you provide in this session and the information provided from other leadership in different sectors of kind of behavioral health and physical health treatment will culminate into a plan and a set of recommendations that will be developed through Behavioral Health Network with the guidance of our technical assistance advisors to kind of tell us what are the steps that we want to do to take forward. So really is important to utilize this time together and get what we can out of it. So thank you so much for your full attention as we go through this, and for your willingness to participate in the activities that we guide you through today. So again, thanks for being here today, and we hope that it's an informative and great feedback session. So thank you, everyone. So what I'd like to do now is to introduce you to the BHN team. Most of you know Sally Haywood, who's been really instrumental in setting up some of this work and helping us to kind of guide it forward. And then she has done a great job of hiring a good team that is going to be working with you all through this. You met Melissa Benson just now. She kind of opened up the door for us, and she's been working on this complex care initiative for about 8 or 9 months, maybe a little bit longer. And I'd like to introduce you also to Chris Walsh. She just joined the BEACN team. Feels like she's been here for weeks, but I think she's on day like 4. So I'm going to let Chris introduce herself so you all get to know her face and her name and know a little bit about her. So Chris, you want to introduce yourself?
Thanks, Wendy. Hi, everybody. My name is Christina Walsh, like Wendy said, and I'm the Senior Program Manager for the Clinical Redesign. I've been a nurse for over 30 years, and during that time, I have a history of managed care, been in managed care for about 9.5 years, and disease management for about 15 years. I've been managing nurses for quite a long time. I have also experience with implementing clinical programs in the managed care arena. So I feel very blessed to be here. And Wendy, I'm going to turn it back over to you.
Great. Thank you. I really encourage you all to get to know this fabulous team. Sally, Melissa, and Christina have just been phenomenal, and we look forward to continue to work with you all. Next slide, I'd like to introduce you to, if you go to next slide, please. Thank you. I'd like to introduce you to the team that we're working with. This is the Camden Coalition's National Technical Assistance Team, 2 members of that team. They've worked with dozens of organizations across the country, really co-creating interventions tailored to unique populations and institutional contexts. Typically, this work, we see it really driven from the primary care needs. And one of the things they noted about our work is the innovation of it really starting with the behavioral health need and then addressing the complex physical with it. So we're certainly excited to have these 2 on board. And what I'd like to do is hand it over to Lauren to introduce herself, and then she'll pass it to Jason, who will introduce himself and then get us started on the content. So again, thanks for being here, and I'll turn it on over to Lauren.
Thank you so much, Wendy. Hello, everyone. I'm Lauren Harden. I'm a nurse and senior advisor for the Camden Coalition's National Center for Complex Health and Social Needs. I've been working with complex populations for almost 20 years, everything from hospice, children's hospice, palliative care, and then solely complex populations for the last 15 years, behavioral health, homeless, addiction, complex multiple medical. For the last 5 years, I've been partnering with sites around the country, and I'm very honored to be partnering with St. Louis. I'm really excited about the innovation that you already have going, and we will bring everything that we can to this project to help support and accelerate your work. And I'll turn it over to Jason.
Thanks, Lauren. Hello, everybody. My name is Jason Chury. It's great to have such a dynamic group here. First of all, I just want to say there's construction going on at my home, so you may hear some banging, but we're gonna. Want to take a second to welcome Christina to the team. We're excited that you're on board. She brings great experience and perspective, especially from the managed care space. So excited to have her on the team.
Thank you.
Oh, you're welcome. My name again is Jason Chury. I'm Director of Field Building and Resources for the Camden Coalition's National Center for Complex Health and Social Needs. I've been working in the field as a nurse since 2004, all from across care management, community-based behavioral health, and even to the health systems level. We get the opportunity to work with organizations and consortiums like yourself from around the country that focus on individuals with complex health and social. So we're excited to be here. This is a series of conversations that we're having across the community, across stakeholders and key domains that we want to impact through Project BEACN. So we'll just jump right in here, and with a very easy exercise for you all. Wendy mentioned it as well. Participation is really important here. So here's our first easy exercise. Could everybody, if you're not familiar with it, which I'm sure you are because we're all living on Zoom, just put your name, position, and organization into the Zoom chat now so we know who's here. We're going to be asking you to participate via Zoom chat in the inclusive part and the interactive part of our presentation later on, but we want you to feel free to add your information there. So I'm going to pause. I'm going to put my information in, and we'd love to see who's with us here. We have over 24 participants, so it's a great group. I see a great group coming on here. Awesome. Well, thank you guys. And we're gonna, and we suggest that you continue to use the chat to pose questions, ask for clarification, throw out your brainstorming ideas. We're taking a record of the chat and we're recording as well, so it's really useful for everyone that's on. Okay, so let's get into the agenda. We went through some introductions. We'll talk about focusing on finance as a key partner in complex care. We'll take a journey through complexity, and I'd love to see the reactions as we work through that. Talk about some cost and utilization trends for this population, work through financial stakeholder management. We have Lauren's going to present on her work at Mercy Health in Grand Rapids, Michigan. Not connected to the Mercy Health here, although a similar name, and providing great care as Mercy is here. We'll dive into that case study. We'll talk about the diverse value propositions associated with the work that we're doing, and then jump into an interactive discussion. Okay, so Wendy posed the question at the beginning, what are the finance folks doing here? And I'm going to use Lauren's words for her. Finance needs to be your best friend in this type of work. To initiate and sustain impact, it's really important to understand the financial stakeholders that are involved in the work. As you can see here from our diagram, or actually our infogram here, you know, many of you are familiar with this concept that there's a huge opportunity to focus on most high need, high cost individuals, right? They're a small group. They account for a lot of the costs and a lot of our headaches. So a tremendous opportunity, but you have to find a way to skillfully partner, right, with all of the organizational stakeholders in order to initially implement and sustain this work. So this is a really important discussion we're having today. Often gets left out in care model redesign. We focus on the clinical aspects. We focus on getting community partners together. But this is a critically important discussion to sustain this work in the long term. Lauren, do you want to add anything here about your perspective on?
So I had very early lessons in this because I worked with very high frequency population and reduced their utilization, and didn't think about the impact on the finances. I was just focused on quality, and it was definitely the right thing to do. But I learned very quickly in partnership with the CFO how important it was to consider the financial model. If you want to get long-term sustainable investment in these types of programs, it's very important to be real about the economic model in our health and social and community systems. If we don't learn about that, if we don't honor it, if we don't partner there, it's often one of the biggest stumbling blocks for programs. So I've had the joy of partnering with many finance leaders around the country, and love talking about this and sharing those lessons. And we're really excited you're all here because we hope to partner with you for the long term on this project. Your finance expertise is critical for really understanding and sustaining the investment in care for vulnerable populations.
Absolutely. Thank you, Lauren. And you said it well on an earlier call, resolving the tension between margin and mission. We all want to do this work. The folks that we're focusing here on are really complex. We want to meet their needs, but how do we sustain this in a sustainable financial model? And that's all of our collective work to come up with that. So that's woven through the presentation here, but just something to keep top of mind, and we're glad you're all here. So as we move into the next slide, we want to talk about complexity. We mentioned this about complex care. So, and we want to, and for the folks that are coming from a financial perspective here, let's take a second to just digest what's going on this slide. So we talk about complex needs in the abstract, and hopefully this makes it a bit more concrete, although this is it can be a complicated slide. So let me just describe what's happening here. So this is Abe, right? So as you can see, so in Camden, I got this, we have this data from our Camden operations. We tracked Abe over several years, not only from his healthcare expenditures, but also his run-ins with the with the police department. Again, this is an example of using cross-sector data to begin to better understand our populations. And if you can think of this from a financial lens, what are the upside and downside risks that are posed here to the various places where ABE is interacting with? So I'd love to see some chats on here on what they're initially saying. And some of you might have done some of these analysis already, where cross-sector data is combined to really look at trends over time. And somebody like ABE would be very similar to the population we would be targeting in a project like Project BEACN. What stands out to me is ABE's consistent utilization across multiple sectors. Also his ongoing level of high need, right, throughout, which is consistent. So when we begin to look for patterns in the data, right, you know, acute utilization, we would expect if there was an acute event, right, but sustained acute utilization and sustained use of, for example, the criminal justice system is something that kind of really establishes a kind of chronic case of unmet complex needs, right? Where we would look to intervene and wrap this individual around with a holistic community-based solution. Lauren, do you want to comment on ABE? I know you recommended us using this, and I think it's great here to think from a clinical and financial perspective.
I love this slide because it really starts to show how many partners there are potentially in looking at this kind of work. And also it's a really important study on what we're trying to do here is not cost shift from one system to another. The more we understand the financial model across the community, the more we can create something sustainable, something that has a cycle of investment for all players, rather than shifting a burden to one or the other. I've worked in communities across the country, and one community in Northern California utilized this kind of concept to do a cross-sector collaborative that included criminal justice and police and EMS and social services and healthcare. When they sat around a table together and looked at how do we redesign our systems, they were able to create very, very positive outcomes, more than $1 million in savings, and also generate a perpetual source of external revenue to fund what they were doing, because people were so excited to see a holistic view of a person being taken and all of these organizations collaborating. So our goal is to really learn from you. What is your financial model from the seat you're in? There's no judgment for that. Everybody has one, and it's really important we understand it and respect it. And then how can we design this so it really respects what each organization needs and creates a sustainable long-term funding for this kind of work?
I think that's really well said. And I think it speaks to the community that we have gathered around this project. This isn't just one sector, right? We have folks from community mental health, we have health systems involved, social services, homeless service providers, right? We have some payers involved, substance use providers. So thinking collectively about this, right? And it's, and here, you know, we're not mentioning like a payer source. We don't know if this person has Medicaid or Medicare, if they're uninsured, but they cut across systems, right? And for example, it's irrelevant if you're in, you know, in the context of a criminal justice situation, like you're still utilizing resources, you know, outside of the bounds of, for example, your health insurance. So a lot to be learned by mapping out individuals across a community care continuum. And we'll get into one of our other case studies as well, but we think ABE is indicative of that. And I'm sure that there's folks on the call right now thinking, oh, I have someone in that I've come across that would probably match or even outdo what ABE did here. So keep this in mind and recognize that, you know, we're all in this together. These are community-wide problems that need a community-wide solution. So in jumping more into the data in Camden, we wanted to put up some utilization data we have in Camden. So we're lucky in Camden to have a regional health information exchange and all the claims for the whole city. So we began to do an analysis and really looking at some of the target population that we're considering in this program. So I think we thought you all would find this really interesting. When we began to cut the data on individuals that had a mental health or substance use diagnosis, and certainly for the program we're talking about here, that's an entry into the service provision. We found that there was a small, costly mobile group of individuals that was circulating through multiple health systems. So we thought about this in the context of Greater St. Louis, that there's probably a similar group. We're willing to bet there's probably a similar group circulating through the systems that are even represented on this call, and utilizing services. Certainly, services are being duplicated. Folks are falling through the cracks. Lauren would call this the Swiss cheese model. So again, these are phenomena that many communities around the country are trying to solve, right? These high need, complex, and high cost, and we'll get into that in the next slide, cohorts, and what are the solutions that can be brought to bear to support them? And when we look at the numbers, they're staggering for these small groups, right? And it just speaks to the tremendous clinical and financial opportunity here, but no one institution can do it alone, right? So here we're bringing forward some hospital-based claims data here that we have access to, and this doesn't even begin to account the other lateral impacts that these individuals are having. Lauren, I know that you recommended this slide as well, and again speaks to like the tremendous opportunity, and we'll get into that. Any reactions here as we look at this kind of, again, staggering numbers here, the tremendous opportunity, but what a challenge to work to bring systems of care together across the continuum to impact this.
I think it's really important here to frame this. So this is just 12 months of data for that small cohort that was accessing multiple health systems, $260 million in charges. And there were only 31 million in receipts. So there wasn't a gain from the increased frequency of access for any of the health systems. And I apologize, I now have lawnmower noise on mine. Who knows what else could happen on Zoom today?
Oh, no problem, Lauren. I appreciate that. Great question here from just as we're jumping, and see, this is where you have to really watch your abbreviations and acronyms here. So LOS, and correct me if I'm wrong, Lauren, I believe that's length of stay. So if you think the magnitude of the impact of those beds being occupied, that's not insignificant on a very small cohort. But again, we know, again, harkening back to the beginning of this, the presentation, that this is a small group that overutilize, right? And but underneath that are significant unmet needs, and underneath that is significant fragmentation, right? And siloing across our system. So again, great opportunity here. And we'll jump into like what can be done here. I do want to show some other emergency department utilization because it comes up here. We really focus, a lot of this work is focused on outliers, to be honest, right? And the challenge that systems have in systems of care and individual health systems, for example, or our community mental health systems have in managing that type of complexity. So for us, and I hope my little, oh, there it is. You know, it just so for folks trying to read the slide, we have the number of clients here frequencing, and the amount of ER utilization over a population. Again, this is using Camden data from our HIE, and it's those groups that are that have, over 10 ED visits, right? Again, it's a very small cohort, but and what we found that there's something, and many times with that type of ED utilization, and Lauren, you can, there's a prototype of the type of the individual or the needs that they're presenting with, whether it be behavioral health or substance use or chronic pain, right? That once you begin to dig in, that there are solutions for those individuals, but they require collaboration within and between organizations. So speaking of an individual that kind of challenged the system, and our initial kickoff summit presentation, we presented Michael. So Michael was a young man, really articulate young man who made a real huge impact on our care team, who actually, we think his case is indicative of someone who really stressed the system to its max. And we think there's a lot of lessons here to be gained by looking at his case. So we put his case on a continuum here to think about all of the upside and downside risk and financial players that can potentially be at stake across a community care continuum. And what do I mean by that? Well, let's look here, like for example, for Michael. He was, police and EMS were called to intervene and to bring him into the hospital on an emergency call. He was admitted through the ED, right? He moves through a hospital inpatient unit. Michael did have Medicaid, by the way, if you're thinking about a payer source, but that just recently came on. He was uninsured for a while. This was before the Medicaid expansion in New Jersey, which had a limitation on individuals with a legal history. And then you can see the other pieces of the continuum here. He needed post-acute, actually IV infusion for a bacterial infection, secondary to his IV drug use. He worked his way through community mental health and substance use providers, and eventually had to be linked to primary and specialty care for the significant physical health complications that ensued. But through it all, we put these out here as, yes, these are clinical components here, but there are financial stakeholders at stake as well. And I added his care plan here about that is in his own hand, again, indicative of the other systems that he is accessing during this, that we're connecting him to, right? That are helping him to regain stability, but also, and don't necessarily have a financial stake, but there's certainly a service provision stake and are certainly part of his stabilization. So I think when we talk about collective community benefit and spreading the incentives around, we have to consider, for example, what about that housing provider that's going to work with Michael to really impact his stability, right? Or that substance use provider, and which will have a benefit to when it comes to reduced utilization from the hospital. So Lauren, I know we were talking about the cost shifting, but I think it's very real when we're talking in a community and collective sense here to really think about that, because it's important, because a lot of community providers are not at this, are kind of almost left out of the kind of these advanced payment models that are coming out of more of a healthcare based paradigm. But we have to, thinking more collectively, we have to be more inclusive, I think, especially if we think about the opportunity here in St. Louis. So we're going to move on. And so I'll leave you with Michael here. And I think we can really learn a lot from his case and then apply it to the work that Lauren did at Mercy, and actually coming up with a model and looking and working closely with finance to implement that. So go ahead, Lauren.
So I'll tell you a little bit of the story when I first got involved in complex care. This was more than 10 years ago. I started a model where I basically raised my hand and said, if you have complex patients, I raised my hand and said, I will look into the case. I will see what I can do. Most people don't do that for a very good reason. But I learned a tremendous amount, and it really helped me to build an effective model. So I interviewed with more than 300 people in that first year through collaboration. So this is the interprofessional team I collaborated with in helping those individuals. And they ranged from young people who are 18 and homeless and just coming out of the foster care system, all the way up to 80-year-olds with dementia and very complex multiple medical needs. We had physicians, nurses, social work, all kinds of risk management, case management, finance, everybody involved to design this intervention and contribute to what was happening. I reported out the outcomes after the first year, and there was over 60% reduction in utilization, ED visits and inpatient. And the executives were very quiet, and I didn't understand why. The CFO pulled me aside afterwards, and he jokingly said, we're going to hold you accountable for a $2.6 million loss in our bottom line. So you have to think this was before value-based payment. This was before any of the incentives around coordinating care. So I was pretty horrified as a clinician, but I reached out to him, and he actually became my best partner in helping me understand, how do you build a sustainable finance model for this kind of work? What can you do to look at all the different stakeholders, really understand the importance of margin being present so that you can support mission, and really working on the cross-system model of delivery so that you got the best outcomes across the community. So I lived in the hospital, but I was collaborating with partners across the community. So the CFO, Dan Green, helped me to understand different ways to scaffold the populations and build partnerships and really look at different revenue sources. Next slide, please.
And Lauren, as you're jumping in here, and this maybe we wanted to go ahead and add an overview of return on investment.
Oh, great.
So I wanted to make sure, because and to Sally, who's out there, making sure that we're staying on point when it comes to our abbreviations and acronyms and our jargon. For some folks on the call, return on investment might be a nebulous concept, and Lauren's certainly going to talk through. But the idea of, like, the money that we invest into a program, right, for staff, for supplies, that we're seeing a return on that. When we apply that to complex care, and I love the way the Commonwealth Foundation, if you haven't checked out the Commonwealth Foundation, I put their information here in the slide. They actually have an ROI, or return on investment calculator, but they said it really well in the context of complex populations. They said, sustainable financial arrangements concerning ROI really are there to fund the delivery of integrated care for individuals with complex needs in a sustainable long-term way. And again, these clients who account for, as we've seen in the data, a large share of the overall healthcare spending, often have multiple complex needs. And they mentioned, wraparound models really have been shown to impact these groups. So again, ROI is kind of fancy language for a sustainable financial arrangement. What does that mean? That you can cover a lot of the costs, or even do better and gain and bring revenue in to support running of these programs over the long term. I'll say one more thing. Many programs stop at the pilot phase and aren't able to establish this. So if you can establish it, you then make a successful business case to move the work forward in the long term. So I'll go into the next one, Lauren. There you go.
Great. So we went on to intervene with another 339 patients and did a study of what were their costs and visits for 12 months before intervention, and what was the impact after. And what we found by coordinating care, doing this well across systems, and really intentionally reaching out to our highest utilizing clients, or our highest utilizing customers, we were able to reduce admissions, reduce emergency visits, reduce inappropriate outpatient utilization. And the net revenue did go down, but the direct expense reduction was so much greater than the loss of revenue that the actual operating margin of the system increased. That matters a lot if you're a CFO. And as a clinician, that was new language for me, but understanding that if I built a model that respected the financial imperative, or the financial underpinnings of how every system works, that I would have partners and I would have investment to really go deep in doing the right thing for vulnerable populations. So we did that together. Then the success of this model resulted in almost $1 million grant from the Trinity Health system that we were part of. Trinity Health has 96 hospitals across the country. So then I was able to intervene with over 1,000 patients. So if you go to the next slide. So for the CFOs, I think this will make the most sense. What we modeled out with that original grant was they had planned to invest $3 million over 5 years in the program, and they estimated that there would be a 28% return in 5 years. And the targeted population was 900 patients. What I was actually able to do with that initial investment of $760,000 in 2 years was to serve more than 1,000 patients. And our actual return on investment for that model was 23% in 2 years. So doing the right thing holistically, really meeting the needs of these complex patients and doing it collaboratively across the community resulted in a very positive return for everyone across the board. And that resulted in permanent financing of that program. Next slide, please. So another example, what we've done is take the lessons that we've learned from sites around the country. So who else has done this successfully? How have they done it? What kind of economic models tend to make this work really well? So for the last 3 years, I've been working with Regional One Health in Memphis, Tennessee to design a model. And I actually just met with them today. They are now 3 years out from starting that model, help them design it, train the team, and continue building the team. They just finished analysis of their first cohort of patients who are 12 months out from intervention. And they served 430 people in 18 months, which is a very large number for a new program. They did this through really intensive, holistic, whole person care and partnerships across the community, addressing root causes like social determinants with transportation and housing and access to behavioral health. Their focus, where they started, was all uninsured patients. Regional One is in Tennessee, so they did not expand Medicaid. They have a 30% uninsured rate of the population. What happened by doing the right thing, linking people to services, they found many of them actually qualified for benefits, but they had health literacy or language or just a lack of understanding of what they qualified for. By connecting people to benefits and really stabilizing them, the health system ended up with $5 million in additional revenue, and that was for a cohort over a year. They also realized $11 million in cost avoidance. So that program also has been permanently built into the budget. So as we look at this, we're very interested in learning, what does that model look like for your organization? What's most important to you? How can we respect the levers that are driving the organizations in this community so that we build this in a way that you have permanent sustainable change for your community and for the vulnerable populations?
Lauren, I love the way you're saying that. And I also think that there's, and the Tennessee and the One Health program is definitely a one definitely applicable model. But I think the work here in St. Louis takes this to another level, considering the amount of collaboration that's going on. We've said this at several of our meetings here. There's such an organization of stakeholders here and leaders right across sectors that a model like this would be really useful to for communities with similar needs, right? So I think what you're developing here, obviously it's going to have a local impact, but I think could play nationally as well. People trying to figure this out from a community-wide perspective. So super excited that way, and I think that's going to lead us into our thinking about a value proposition. So, and what do we mean there? Like, what is the business case, right? What is the and clinical case? They go together. And as Lauren, I really like what you said about return for everyone, the individuals being served, the community at large. Here, there's a lot of financial underpinnings, which we have to consider. So we wanted to bring this up as there are many value propositions to consider here. In previous discussions with you all, many of you have said, for example, you are in alternative payment models, and that could possibly be an incentive and add value for a program like this. Many of your institutions are dealing with significant uninsured populations that present challenges. As Lauren was saying, Regional One in Memphis, there's a significant issue there, right? Many of those folks were able to get on insurance, and then we were able to find a payer source for the services, and we were able to reduce unnecessary utilization as well. So I do want to give a little bit of time on the government programs as well, because there's distinct needs even within each one of them. When we start talking about, for example, we can focus on the Medicaid population right now, but also within that, there's an opportunity, as we mentioned on previous calls, with behavioral health homes in Missouri, which are connected to under the Medicaid program. Our CCBHOs, I want to thank you for Sally for mentioning this too, that model is a real player here in Missouri, right? And one that can be also spread nationally. How does that play into this? And I know we have a lot of community behavioral health representation here. I've been really impressed with the advances that have gone on in community health in Missouri. So I'd love, as we get into the discussion piece, I'd love to know about, okay, how does CCBHOs play into the value equation here? And then we mentioned some things that you might not have considered. Dually eligible populations, which are folks with Medicare and Medicaid, present an opportunity. And then TRICARE, if you're not familiar with that, these are This is an insurance product for veterans, which have unique populations a population has unique needs in and of themselves. And I'm sure many of you are serving veterans in the greater St. Louis area. Lastly, we'll finish off with community collaborations and collective benefit. And we've heard this theme coming up consistently in this call. Certainly the work that we're doing, I would say, and I don't think I'm over speaking here, Lauren, many conversations are quickly going to, when we start talking to payers that are working across regions, health systems that are working across regions, that collaborating across communities has the potential for a larger community-wide and collective benefit. And we have to figure out ways of not only, sharing the risks and potential gains there. And these are new models. This is an emerging concept. So there's not something we can take off the shelf and just apply here. What I do see is a solid foundation being built as BHN has done a great job in organizing the leaders of this community to come together around individuals with complex needs who we know have extremely high utilization across sectors and preventable costs. So I think we're teed up really well for to begin to build something here.
And there's really a lot of interest on a national level as well. I had the privilege of being added to the PTAC group, which is reports to the GAO. It's part of Health and Human Services on the national level. That group reviews all proposals for models for alternative payment, gives opinions and recommendations, and then those are passed on to the CMS and the Center for Medicare and Medicaid Innovation. As part of that, I have a window into what are they paying attention to and what are they interested in paying for in this next phase. And there's a lot of interest in the financial model around funding these types of collaborations. So we'll keep you linked into that and are happy to seek out any resources related to that if you have a particular interest.
Thanks, Lauren. And we may be missing something, so that's why we're going to be asking you all a lot of questions here. So we're about to move into the interactive discussion piece here around the financial goals of this project and more broadly in complex care. But I want everyone, I know we're all sick of Zoom and I know we're all multitasking, but your participation is really important. And we want to make the best use of your time. So you're here, we're going to be posing questions coming that are directly related to the financial goals of this project. We would love for you to respond via the chat. If there's something discrete that you want to send Lauren and I, you can send it right to us. We'll keep it all anonymous. But we really we want to have a space here for interactive discussion, even coming on camera and vocalizing your opinion as well. So why don't we go through these questions? We have plenty of time for crosstalk. Again, we don't have any, we have some ideas to bring. Our job here is to facilitate discussion with you all as a really engaged community to collectively work towards solutions here to implement and sustain this work. So we can start with the chat here, but each of you are leading initiatives at each of your organizations. And we would love, from a finance perspective, this first question here, what keeps you up at night? What are you worried about? This varies, again, across everybody's priorities, everybody's organization. So I'm going to wait for some chat to come on in. But if you could take a second and think about what are the issues from a financial perspective that you're really concerned about, especially in the context of the models around these higher need populations, that would be awesome to start to have conversation on. So, and I'll be calling on individuals that have really interesting responses here. So yeah, we'll wait for you guys to input some ideas here. Yeah, and as Sally's saying, we're using your feedback here to really, across the multiple goals of this project, to really inform some strategic planning and some recommendations for moving this work forward. So again, the more we participate, the better informed we'll be as we move forward. So I know we have a great group here. So, and as you're considering that as well, I wonder if anything from the value proposition was standing out that we left out or that specifically spoke to you all in your operations. I don't think we were inclusive of everything, but we tried to consider the participants on the call and what would be of value to them, and what keeps you and what keeps you up at night from a financial perspective. Sally, keep the ideas coming here. Absolutely. So Laura McAllister, thank you for participating there. When it comes to the uninsured populations, and I think Lauren can speak to this directly in the work of Regional 1, I believe that was the sole focus of the intervention, right? Identifying these individuals. Some of them were probably eligible because of their conditions for Medicaid. Certainly many of them had issues with chronic homelessness and other issues as well. Lauren, do you want to talk about how the system there began to target uninsured individuals as we have other folks putting information? Like, I feel like we have a use case out of Regional 1 specifically here, right, in intervening. So I'll let you go, and we'll see if other folks are going to input.
It's a really important population. So we worked with them to help them look at their data to see the opportunity and see how did the uninsured population tier out in their data. So, there were people that came once in a year, and then there was this small group that had really high utilization. So we helped them build reports so that on a daily basis, they could identify who was in the building, who was uninsured and was a higher utilizer, and who was in the emergency room today. A lot of times for people who are chronically homeless and uninsured, there's been a lot of broken trust, and it's very, very important to meet people where they are. I'm sure that many of you know this work deeply. But what was very successful for them was meeting people right at the emergency room and in the moment of care, right inpatient, and then locating their team in a way where they were very convenient to that population. So they were located very close to the shelters. They were located very close to some of the key food pantries. So they met people at the point of where they were, really came in from a perspective of offering what mattered most to that person and how could they address that first, and offering a different level of support. And then truly did wrap around of all the root cause issues, from not having a job and not having benefits to really not having had chronic disease management for years. And then getting very creative about how they solve some of the really tough root causes, like lack of housing with felony records, or lack of recuperative housing for homeless people who are coming out of the hospital. Meeting people where they are, and then really deeply looking at developing rapid cycle access to things like Social Security disability through SOAR, paid medications, other benefits and entitlements as quickly as possible. So
Lauren, Rob Poirier had an interesting comment, and he's been a committed champion for complex care and spearheaded the Barnes Hospital's Familiar Faces initiative. Rob, would you be willing to verbally describe your comment just a little more?
Sure. So yeah, the biggest thing that keeps me up at night is mostly focused on the self-pay and Medicaid patients and the barriers they face to access to care. And it's access to care pretty much on a schedule that fits with their schedule. This is a population that often needs to work, can't always make appointments during Monday through Friday, 9 to 5, or the business schedule where the bulk of the work gets done. And so I don't think we've adapted our healthcare systems to accommodate that group. We accommodate ourselves and our business, but we don't always have the patient-centric focus in mind. And I think to get buy-in, to get compliance, to convince patients to adhere to care plans, you really have to work with them and have shared decision-making and shared opportunities to access the resources they need.
That's so true, Rob. And it's so great. I've heard a lot of great things about the program that you have. Have you all tried to address that with process improvement changes or different changes across the system?
Some parts, we're trying to go to, because we're so overloaded and overcrowded, we're trying to go to a 7-day-a-week, 24/7 hospital. But that definitely impacts margins. And then you put in COVID and you put in all the changes in healthcare financing. It's not easy to really, you tend to go back to your defaults. And so it's hard to get, it always feels like one step forward, 2 steps back.
Mm-hmm. Yeah, completely understand. A lot of the sites have ended up needing to go in a very creative direction about how do you bring care to where the people are in a way that's convenient. It's changing the whole system can be really hard. So like you were talking about office hours and access and all of those things. But they've also looked at creative solutions, especially for the high utilizers, about how to bring the care to where they are. So whether that was nurse practitioner rounds in the homeless shelter, to have a primary care and behavioral health presence and delivery. Or if there's a neighborhood connection, what could the neighborhood hub look like where the care is brought there from a mobile perspective? And then what are the ways, what I've seen with these teams that have taken on this population and build that trust is they're able to do a lot of remote managing and coaching and support because that front end trust is developed in person. But it's a really critical point. Shirley, did you want to add to that?
Not really. I agree with Rob around those issues of we have not made it easy for people to follow up and get the stuff that, the kind of care that they need, and it just ends up resulting in higher costs and poorer health outcomes. But and I'm kind of hopeful that we had to do some things very different around COVID. There were a lot of people who didn't believe that they could do any kind of televisits would be of any use at all. And we have found that has worked very well for a lot of, not only the patients, but the providers like it. So, maybe stepping outside and saying, okay, how do we leverage this crisis that we've had to see how we could do some things differently?
Mm-hmm. Mm-hmm. Great point.
Yeah, and Lauren, as Rob is mentioning this, and being a former nurse from the emergency department, I'm thinking, if you don't have insurance or you have Medicaid and you need a specialty appointment for, let's say, something that you present at the ED a lot for, like asthma, right? And you can't get that, you can't even get a follow-up appointment. So you're using the ED as a place that has, to Rob's point, the lights are always on, the doors are open. I can just walk in there if I'm having an issue managing this condition. I can see how that could be really frustrating from the provider side, that you're doing everything you can to stabilize there, sending them off on their way. And Rob, to your point, the system isn't set up to be responsive to that. For example, getting a follow-up appointment when with this type of insurance status could take weeks, maybe months. And maybe there are some standout clinics that actually can offer more from some better access. But that's what I hear there is a frustration that the systems just aren't responsive to the needs of individuals with, again, from a self-paying Medicaid perspective. But I think we could probably apply that more broadly. So thank you, Rob, for that. I appreciate that.
Mm-hmm. How about from some of the community organizations? What is the population, or the finance issue that keeps you up at night from a social service or community organization?
Lauren, I'll continue on that. We're really curious about how, especially the community mental health providers that are on the phone, the incentives around, growing from the CCBHC to I think I'm saying this right, CCBHO model, and the potential there to enable your operations to better wrap around the individuals you're working with. So love to hear from the community providers. I think play such an important role and such a important part of this collaboration, whether from behavioral health or substance use, or we may even have some social service or housing providers on that. We'd love to hear your perspective as well. As I was just reminded by Wendy, and thank you for that, we're some of the jargon here around value proposition. And if nothing else, hopefully we did some teaching in this exercise in our webinar today around ROI and value proposition. But I tend not to overcomplicate this term. This is really, what are you proposing the value of your intervention to be from a clinical perspective? For example, this is designed to reduce ED utilization, emergency department utilization for individuals with severe anxiety, for example. And we can, we've run a pilot implementation of this, and people stay out of the emergency room, and we've done some basic financial calculations, and this is what it can potentially save in avoidable emergency department costs. So that's just an example of basically constructing a very clinical and financial equation in very simple terms, doesn't have to be overcomplicated, around the value of the intervention that you are proposing. I wonder if we should move maybe to some other questions, Lauren?
Sure.
Okay. I did want to, before we jump to, and I'm sorry for jumping, the financial metrics component, I think this is really, and Rob, thank you again. So we should talk about these terms here. So Rob, again, if you want to, we would love for you to participate. If you want to narrate your response, that would be great.
Oh, yeah. So from what I see, and kind of from where I sit, it's the financial metrics ultimately come down to margin. And so healthcare organizations typically run at such small margins. It's really difficult to take a chance on big, impactful innovation because it may or may not pay off. And when you only have a couple percentage points when dealing with your margins in healthcare systems, and if you go below a certain margin, all of a sudden everybody loses bonuses and incentives, and so you're incented not to go below that margin. And so it's definitely a more conservative and cautious approach. And then with all the complexity in healthcare financing and changing, whether you expanded Medicaid or not, whether you get DISH funds and government add-on payments or not, how you qualify for that, it's really, you have to, the system performs the way the finances kind of encourage it. And so from my perspective, we really need to change the way the financing of healthcare flows currently, because we're getting exactly how it's designed to kind of incent organizations to perform.
Hey, can I brag on Rob? Not only does he lead one of the biggest polytrauma ER units in the Midwest, but he mid-career went back to Washington University's executive MBA program. And so we get a very unique, informed perspective through Rob. Did I say all that right?
Yeah, that was too generous, but yeah. My eyes had been opened a little bit learning the business side, and then learn. You have to look at the macro and micro perspective, kind of from a perspective, and it's like a chess game out there. And we're just trying to strategize the best way to get the best care to the most number of people in the system that we're made to perform in. So I'm always looking to change it to make it better.
How did you get support for the Familiar Faces program, Rob?
It was kind of homegrown, and we just said we knew this was important. So initially people just volunteered extra time. We're salaried here. And then over time, we saw some improvement, but we haven't received the infrastructure that kind of like a Duke University or some of the other universities put into it and dedicated. But over time, we've just made it part of our operations, and slowly we get more and more resources. And then we knew it was important to network with the community. And so inviting them to the meetings and reaching out and having more conversations. We tend to operate in silos, and when you set up operations that encourage outreaching and networking, that makes a difference, especially because nobody's really making extra money on this. And you don't really realize if you save money on a patient, you really, in the healthcare system, you lose money on the patient. It's not like from a macro perspective, it makes a difference, but not from the individual micro perspective, even though we know it's the right thing to do. And it makes us feel good too. It helps with your resilience and feeling good, because we all went into healthcare pretty much to help people. And so you want to feel like you're helping people. So I think it crosses those two segments right now. So.
Rob, you bring up a good point. The kind of the mission focus of and I think this is a good case study. The mission focus of it feels good. It's the right thing to do, but I'm curious, how is it being? Is it just a sustained on good feeling, or is it maybe provider advocacy, and maybe it's just so aligned with mission that it can sustain itself that way. But I think a lot of programs have struggled sustaining well-meaning interventions that have an impact that don't necessarily that have maybe a clinical impact, but the financial gains are not as clear. What advice would you have for the group here as we put together something very similar? Right, we're going to be focusing on individuals that are overutilizing acute services and trying to wrap them around and sustain them in the community. And many of these individuals you interface with in your emergency department.
Yeah, I think it's telling the story how we all benefit as a community, as a system. You have to show everybody what's in it for them, and the value add, and that's very important on a project like this. And what can be done when the health systems and the health networks out there are all working together. You may not recognize an immediate financial benefit, but over time you will. It's thinking more. You have to have a long-term perspective rather than the short-term perspective we're programmed to really look at on a quarterly or annual basis when we see what our budgets are and how many people we can hire, and going from there. And not all those of us doing the work, the cost savings that we're generating and doesn't always come back to our departments or to us. And so over time, you do all this work, you get the mission feel good benefits, but you're not always getting or receiving the value benefits to enhance it aggressively further or really change things to make a difference. So I think it's really about the story, getting the leadership aligned with it, getting the state and city and county aligned with it to make sure that the value is shared by all, and that then you're putting that value to better use to improve things even further.
So I'll confess I've been privately trying to nudge people to share. Laura McAllister has served for a long time as CFO and now CEO of an extraordinarily innovative community mental health center that is committed to intensive outreach and healthcare to the homeless. So Laura, things you might want to share? Or Karen Bradshaw manages a community referral coordinator program that helps hospital patients get connected to ongoing primary care. And she's done some really interesting fiscal study of the impact. So I privately know of some of the miracles you guys are doing. If these questions resonate to you in your work, please share.
This is Karen. Just adding a little bit on what Rob said, I think it's really important to have a broader view than just the one organization, the one department, the one hospital. I know a lot of these efforts really talk, and obviously they're geared to hospitals, but a lot of time it's also cost shifting. So when I've done work with looking at folks who use emergency rooms, I did with Mercy St. Louis the most, but Mercy, all 3 hospitals that we work with Mercy. We're looking at utilization, looking at the impact of working with one of our community referral coordinators. We started off by just showing the decrease in utilization, and we started looking at where, in partnering with finance folks, where those costs were. And one of the things was also looking at, for folks who are uninsured, those costs change, but they just shift. And so looking at taking it as a victory to see an increase in outpatient labs as opposed to doing them in the ER. And then when Rob was talking a little bit about, healthcare systems run on such small margins, when you started talking about community providers, those margins are even smaller. And the realization and the needed partnership between health systems and community providers, and the understanding of how each are, where their revenue does come from, and the really importance of understanding, especially as we move towards more population health centered types of things, how important it is that patients who are assigned for care somewhere get back after a hospital. How do we do that? How do we do that with data? All those things impact the financial impact of programs like this.
That's so well said.
And certainly, Matt Mendriff and Kyle John, you would not be speaking on behalf of your hospital system if you wanted to share your particular perspectives about what keeps you up, or around fiscal matters or value proposition. This is really asking your personal opinion. So.
Yeah, this is Matt Mendrup, SSM Health. Again, appreciate the time here. I completely agree. It's the uninsured and it's the Medicaid population. So it's such a vulnerable population that cannot be connected, or very challenging to be connected with services. They have high utilization rates, right? Like the asthma, I think, was a perfect example that we might be able to, successfully treat a mental health issue, but the secondary, third, tertiary issues that bring a patient back to the hospital, the lights are always on, right? So I think it really does take a massive team, a very eclectic team, to address those needs in the St. Louis area. So that to me is exactly the same issue.
And this Dr. John, I would totally agree with Matt. I actually live in Springfield, even though I work in St. Louis area, and it gets worse outside of St. Louis regarding the uninsured and the Medicaid, Medicare populations. It's just tough. I mean, learning to manage to Medicare, so to speak, is one thing, but learning to care for folks that have, we refer to it as mercy insurance, because we're going to end up paying for it. It's a whole different game, and that's probably what up in terms of behavioral health, where we don't make any money anyway. We're doing good to break even on a great day, and then to have our ERs and our units, not inundated, but certainly heavily populated with folks for which we're going to receive no reimbursement. I don't know how it could not keep you up at night when you have to go back to your overall leaders and report out on how much you lost this month or this quarter or this year. We need a different approach. And frankly, I love the Beacon project that Mercy has undertaken because it's a great example of finally convincing some senior leaders that, hey, if you're going to spend, you know, if you're going to lose $3 million in a year, what about spending $1 million to over 3 years to try and decrease that? It makes sense. We'll see if it pans out, but I'm excited about this opportunity.
Hey, I know I don't want to call people out and if they'd rather share via chat or privately or offline, but Lauren, I mean, you help run a community mental health center with an enormous health FQHC connected. So the volume of clients and patients. And Gary, yeah, we have very few folks from the substance use world who are weighing in some of these site visit meetings. So your perspectives from that world would be really useful.
Yeah, this is Lauren. Thanks, Sally. Compass, we are a CCBHO, so we have our PPS, we are at FQHC, and then we still have some of our programs that are still fee for service. So we're always having a lot of fun trying to figure out which bucket, goes where and how much more we can expand the other bucket. And we still provide a lot of charity care, millions and millions of dollars worth. Last year, I believe it got up to almost 19 million. So we just kind of figure it out. And I would say from even just prior experiences before coming to Compass, my experience, especially with running the first of the state crisis center, which was solely based off of a public-private partnership. So it took a lot of community investment to identify, money from the actual hospital systems, money from the city, money from the state, and then money from a private entity as well. And when that funding runs out, I mean, I think that the whole purpose is to gather all of those community partners at one table to discuss everything that you guys have already kind of hit on and mentioned, that, you know, we have to look at the bigger cost savings. You know, EDs still have to staff at the ED capacity regardless of how many people are coming in. So sometimes that they don't see the dollar savings on a daily basis, but their throughput, you know, gets helped because Joe isn't sitting in the ED for 3 days anymore because we have this advanced, you know, outpatient system that can show up on the spot, take Joe to housing immediately because we have flexible funds to help pay for, you know, for lodging and support and medication costs and engagement. And that's so much less than continued ED costs, as well as continued ambulance rides. And unfortunately, a lot of the folks are uninsured, but another population that I think chronically keeps me up are the underinsured, are commercially insured folks, the ones who maybe actually do and need and would benefit from case management support, but that's not covered under commercial insurance. And then their deductible is so high that they aren't able to continue in treatment. And so I feel like, plus the center themselves, those are some of the lowest reimbursement rates for us. You know, Medicaid is our highest reimburser. And so, you know, unfortunately, that's an issue. And then in Missouri, we're capitated. So even though we may have somebody who is on Medicaid, you know, our allocation only goes so far and we have to match all of those funds. So, you know, at some point that becomes an issue.
They're great points, Lauren. It was so well said. And it's such a great picture from the community side. And was, Sally, you were asking also, was it Gary from substance use?
He's at Queen of Peace. I mean, Gary, I don't hate to call people out so pointedly, but thank you for being here. That's it. That's good enough.
Great.
All right, and Calencia, I think you're from BJ Hospital Center for Clinical Excellence. Might you be willing to say a word about how these questions touch on the work that the center's doing?
Hello, can you hear me?
Yes.
Hi, yes, of course. So my name is Calencia Mitchell. Yes, I work for the Center for Clinical Excellence, and we've been working on an initiative called Hospital to Housing that does address super utilizers of the Barnes-Jewish Emergency Department. So it's a partnership with St. Patrick's Center as well as with Behavioral Health Network that's really targeted as a housing first strategy. So housing folks that are super utilizers, that are also homeless, that have that mental health as well as substance abuse diagnosis, placing them in housing and then with wraparound services. And I'm just listening to kind of what other folks are saying today, because we're actually in the conversations ourselves now with the project team at the Center for Clinical Excellence and then those at Barnes-Jewish Hospital about how we really do develop the value proposition for the health system. So that way there's an ROI that's recognizable, that we're providing impact. But that's a program we've had going on since May of 2019, and it's grant funded and set to run through May of 2021.
That's great, Calencia. Thanks. I know that program has made an enormous difference for the people who get to go through it.
Yeah, we've been fortunate to be able to see some great reductions in ED utilization as well as a cost savings that's been realized for the hospital when we take a look at some of the costs that it would take to, care for these patients and the services that will be provided.
That's great.
Yeah, and just to piggyback on that, I think a lot of health systems, payers, and I'm not sure if we have any payer representatives on the call, are thinking about ways to leverage those, right, institutional dollars to support like these fundamental social determinants. Again, with a proven model like housing first, or the behavioral health side, like for example, an established model with, a positive return is something like assertive community treatment, right? So, those models are out there. It's interesting. It'd be interesting to hear more about how Barnes is going to, to our questions here, what are the outcomes that are really going to be helpful for that institutional investment that they're looking for, right? It may not be, a housing outcome for a health system is an interesting thing to consider, right? But if it supports another secondary gain, that's important and maybe enough to justify investment.
Yeah, that's our hope for sure with hospital to housing, that we can justify the health system possibly in the future investing in a model like this if we see the outcome not only from the clinical perspective with patient outcomes, physical and mental health outcomes, but also a financial savings or savings in reduced unnecessary ED utilization that increases capacity in the hospital emergency department for other patients that would have a higher acuity of care. Not just those that are maybe seeking shelter in the emergency department as a result of housing instability.
I think you're hitting on an equation, like a holistic equation there, right? You mentioned cost, you mentioned acute utilization. There's a quality of life component there as well. There's also a recovery and functional status component that happens when someone begins to get wrapped around and stabilized, especially in a supportive housing environment. That all needs to be accounted for. And speaks to different stakeholders as well, right? So, thank you for overviewing that. I think it's a really powerful model. I think, again, I think we have examples here across the continuum in St. Louis of, pockets of innovation, models that can be integrated and potentially brought to bear here. Lauren, what are you thinking?
I think that's great. I'm curious how many people on the call are currently doing analysis of high utilizers or have a high utilizer model going? Because it's really exciting to hear about these.
This is Matt Bendrup, SSM. We have a high utilizer kind of list that we use from time to time, but nothing consistently. But we have year-over-year data as well.
Great. And Matt, you're from SSM, is that right?
Yeah.
Yeah, SSM Health, behavioral health.
Great.
Just a question on that too. So it's great that you're right. One, bravo for creating the list. How has it been used in the past? Is it used to kind of for proactive outreach or targeting when there's, for example, a triggering inpatient event?
Yeah, so it's it's been used in various different ways. The kind of the best practice is that we have a list of patients that we set a barometer of, whether it be 4 admissions a year, 6, 2. Sometimes we change that depending on to get the appropriate sample size. And then what we do is we do kind of like a root cause, do deep dive into the charts, what brings them in, any sort of secondary symptoms, diagnosis, things like you mentioned, any non-behavioral health components that they have that we can work on, kind of treatment recommendations. Did they follow through with, follow-up care, things like that. Really kind of just a deep dive into what can we do differently when Johnny X patient presents to us again, or can we kind of be proactive, reach out to community providers to help connect him. So it really is an SSM kind of approach to looking at that, but it does leave a lot to be desired. It's pretty, painstaking to go through a lot of those charts, and but it does have some good, gives us some good data. Like a lot of it, there are co-occurring substance use going on, so you may present with an acute episode, but really it's the substance use that's driving it. So it really helps us really get a good gauge of year over year who's presenting to us, the reasons why, and allows us to be a little more proactive in treating that patient.
Mm-hmm. And you mentioned it's painstaking. I think you're right. And where many organizations struggle is having an incentive to actually do that work. I know, coming from a community mental health perspective, we were asked by payers all the time to do, and there was no real incentive to do these types of population health management activities. There were some slight bonuses around this in some of the initial value-based contracts. I'm thinking about some of our work in Indiana. But do you see a financial incentive for your organization to do that type of work and do that type of targeting? And it's part of some of our follow-up questions here around value-based arrangements. Is that something that is on your radar, or something that the organization is involved in?
Oh yeah, absolutely. And we're just kind of coming out of the COVID pandemic crisis, and are really beginning to look at this again. So it's a good conversation to have, and looking at better models of care for these patients as well. So, but obviously, yes, there's a huge financial incentive to help treat these patients more on a proactive basis, and trying to fit the patient's symptomology where we can best treat the patients.
Thank you for that. I appreciate that. And that was, we wanted to kind of finish off the conversation here around the incentives that are being aligned. Now they differ across sectors, but as you were referring to, there seem to be some risk-based arrangements. I know some of the health systems have mentioned them. I'd love to hear from the community-based provider, especially on the mental health side, about kind of spotlighting some of those initiatives to actually have the incentives to do this type of work, beyond just a fee-for-service model, which can really be a kind of a vicious cycle, right? Especially from the community mental health perspective, we all know, I'm not sure who mentioned it, margins are razor thin, and it's very hard to change margin, especially at these reimbursement rates. You can increase revenue, but margins stay pretty much flat. So are there other groups on the call? I'd love to hear specific, and thank you for offering that from the SSM perspective, around value-based arrangements that could provide an incentive to target these high-cost, high-need individuals? And I know we only have a few minutes left, but I think this is a great spot to start on, to stop on here, because I think this is going to help us facilitate the work. I think aligning incentives is really important here. Thank you, Sally, for this. So yeah, just broadly, I'd love to see if folks can chat us. Love to hear about we think these value-based arrangements present an opportunity really align. And actually, as was just mentioned from our partners at SSM, you know, the financial incentive is actually what's called, you know, is leading to, you know, these process flows to begin to target these individuals. So it goes from, you know, being the right thing to do to the thing that we have to do in order to innovate and to grow. Lauren, I know that a lot of systems are, you know, and across, you know, and you work with systems across the country that are leveraging these value-based arrangements and their community benefit arrangements to really focus on these populations. Do you want to close out with any descriptions there? And then I think we could probably, if we don't get any, as we wait for more folks to respond.
So this has been really helpful, and we really appreciate all of your attendance and active engagement. We'd love to reach out to you again. Our ideal is that we're going to be in person with you in St. Louis, because we would much rather be in a room with you talking about these issues. But everything you've shared has been really helpful. Are there any last suggestions you have for us about the most important person we should connect with in your organization regarding the business case or regarding finance as this work goes forward?
As folks are thinking about that, and many of you might be that person.
I also promise we won't cold call them. If you share their name, we'll reach out to you and say, what do you think is the best way to introduce them to these, who we are in these conversations. But if you would be willing to share, saying, hey, at my place, this is the person whose perspective we really want to engage, that would be great if you'd be willing to share it.
So we look forward to building this with you, and I'm going to turn it over to Melissa for the close.
Thank you, Lauren and Jason, so much for everything. Also, thank everyone for attending. I wanted to mention, Wendy mentioned in the beginning that this is one part of a multi-part feedback sessions. There's already been one feedback session, which is the Data and Health Information Technology Sharing and Integration. That was last Friday. Coming up Tuesday, October the 6th, there's the Comprehensive Assessment and Authentic Collaboration. And then October the 14th, Wednesday, is our Metrics and Evaluation. Both of these will attend, would be the organizational and clinical leadership. However, next week, we really hope that we have not only our clinical leadership and clinical managers, but also our intensive outreach staff. This will help us build those discussions and ways to integrate interdisciplinary case conferencing and care planning. And again, as we mentioned, this is part of our virtual site visit, and we thank you all for attending. We know your time is very precious. If anybody pending any questions or anything, that's all I have. Oh, I'm sorry, hang on. There was a comment from Rob in the chat.
That's great, Rob. Would love to talk more with you about that. I think that really makes a big difference, and it really starts to shift the conversation. So happy to bring forward any resources from PTAC and CMMI that will help with that. And just we really look forward to continuing this work with you. Thank you all so much.
Yes, thank you all, and have a wonderful rest of your evening.
Everyone, take care.
Thank you.